guidelines as recommended by the American Heart Association. So there are some changes which are being recommended by the AHA with regards to the CPR. First change is the high quality CPR for all age groups. In these changes, the first change is minimizing interruptions. Whether it is an infant or a children, interruption in CPR should be minimized with pauses in chest compression lasting less than 10 seconds. Compression technique, they have emphasized that for infants, the two-thumb encircling technique is recommended over the previously recommended two-finger technique. For it is found that the two-thumb encircling hand technique is much better if we are comparing the depth and the quality of resuscitation. So especially for the infants, prefer the two-thumb encircling technique over the two-finger technique. This is the first change in the quality of CPR with regards to the infant children and infants the technique. Then chest compressions. For newborn, it may be reasonable to compress over one third of the sternum. Lower third of the sternum has to be compressed, ensuring that we are not compressing the xiphoid process to reduce the risk injury. Compression rotation. It may be reasonable to change compressor every 2 to 5 minutes to maintain an optimal compression quality. So every 2 to 5 minutes you have to change the compressor so that the optimal compressor quality is being maintained. And in newborns, avoid injury to the xiphoid process. So lower third of the sternum to be targeted for chest compression. Another guideline regarding ventilation and oxygenation. The ventilation rate. When ventilating an adult patient in cardiac arrest, it is reasonable to give enough tidal volume to produce visible chest rise, and the recommendation is 1 in every 6 seconds. Pediatric ventilation. Always prefer video laryngoscope, which is not recommended for newborn intubation, and a laryngeal mask airway can be used as an alternative to endotracheal intubation when face mask ventilation is unsuccessful. So they have adopted again laryngeal mask airways and use of video laryngoscopes. Another change, the opioid related cardiac arrest, naloxone administration. It is recommended that the trained rescuers, lay rescuers and bystander administer naloxone to suspected opioid overdose cases during cardiac arrest, ensuring it does not interfere with the high quality chest compression. Community initiatives emphasized again that the lay rescuer training has to be performed. Emphasis on increasing public access to CPR training, including community-based initiatives to improve lay rescuer response to out-of-hospital cardiac arrest. So they want that a lay rescuer should undergo a training so that these rescuers, when once trained, can help in improving the outcomes of the out-of-hospital cardiac arrest. So again, emphasize the lay rescuer training. Then again emphasized on debriefing and team dynamics. Debriefing post-event, immediate and delayed. That is hot and cold debriefing after CPR event is recommended to facilitate system improvement. Use of technology, feedback devices. Use of feedback devices during CPR training is again recommended for both healthcare professionals and lay rescuers. Why? To improve the quality metrics. That is, it has always been emphasizing to measure whatever you are doing. So how effectively you are doing, always adopt a feedback device. If you are undergoing any CPR training in any institute with any firm, it is highly recommended that whatever CPRs you are being performing, you should have a feedback device to know whether your quality of CPR is adequate or not, whether depth of compression is adequate or not, whether your rate of compression is adequate or not, the mask ventilation which you are performing, whether you are able to get a visible chest rise or not. So for that, you have a feedback devices either integrated in the mannequin or separately apart from the mannequin. Especially, the guidelines have emphasized introducing ethical frameworks. Why ethical frameworks? To guide the healthcare professionals to navigate through complex decision makings. These include principles like beneficence, acting in the best interest of the patient, justice, ensuring fair and equitable treatment for all patients, non-maleficence, the obligations to avoid causing harm, and respect for autonomy, honoring patients' rights to make informed decisions about their care. So, addressing inequalities, there is an emphasis on the need for healthcare professional organization to actively mitigate social determinants of health that contribute to disparities in the cardiac arrest and emergency care. Advanced care planning. The guidelines stress the importance of documenting patients' wishes regarding resuscitation, particularly for those who may not be capable of making decisions in the emergency scenarios. Shared decision making. Guidelines advocate for shared decision making when multiple treatment options are available, emphasizing the importance of understanding patients' values, goals in care choices. Informed consent. In situations when the patient lacks the capacity, surrogate decision making is supported and with focus on substitutive judgment based on the patient's known preference. Termination of resuscitation. The guideline highlights predefined criteria for terminating resuscitation efforts to reduce medically ineffective treatment, thus promoting justice in resource allocation. Research ethics. The document discusses ethical challenges in conducting research on resuscitation, particularly regarding informed consent in emergency situations, and emphasizes the necessity of following established guidelines and ethical consideration. Protection of healthcare professionals. The guideline acknowledges the emotional and physical impact on the healthcare professionals and the providers involved in the resuscitation efforts, advocating for policies and practices that support their well-being. So again, they have come with the protections for the healthcare professionals. So, the 2025 the American Heart Association guidelines, the major changes in the pediatric life support. There are several key recommendations, but some of the major changes are the high interruption in the CPR should be minimized with pauses not more than 10 seconds. This should be shown to be significantly improve the likelihood of resuscitation. Sequence of resuscitation for infants, heel of one end or the two thumb encircling hand technique is recommended. Approach for chest compression. The two finger technique for chest compression is no more recommended. Then comes the management of foreign body. The foreign body, if for a child with a severe foreign body airway obstruction, it is recommended to perform cycles of 5 back blows, followed by 5 hand stressing, 5 back blows, followed by 5 abdominal thrusts. This is in children. Whereas in infant, it should be modified to 5 back blows, followed by 5 chest thrusts. So in infants, 5 back blows and 5 chest thrusts. In children, 5 back blows and 5 abdominal thrusts. Medication administration. Infants and children in cardiac arrest, with initial non-shockable regime, it is advised to administer initial dose of epinephrine as soon as possible. Monitoring, always use end-tidal CO2 during CPR for infants and children with invasive airways to assess the quality of CPR. Neuroprognostication, no single criteria. Again stressing, single criteria will never give you a neuroprognostication post CPR. It is recommended consider multiple modalities when predicting neurological outcomes after cardiac arrest in infants and children and not rely solely on one indicator. Post cardiac arrest. Infants and children who survive cardiac arrest should be evaluated for physical, cognitive, emotional needs to be there for follow-up care within the first year of the incidence. So these were the major highlights in the infants and children who are experiencing cardiac arrest. What are the changes as per 2025 American Heart Association guidelines? Key differences from the standard CPR in the special scenario, especially in the obstetric patient. Team activation, call obstetrician and neonatal team early. Hand position, place hands slightly on the sternum on the higher upside as compared to in the conventional patient to accommodate elevated diaphragm due to a gravid uterus. Manual left uterine displacement, apply continuous left uterine displacement if the fundus is at or above the umbilicus. If it is at or above the umbilicus, always perform a left uterine displacement or use a profiled wedge. If Wedge is not available, at least manually displace it the left side and continue performing CPR. Airway management. Prioritize early skilled intubation, as we know that a prostatic patient has airway edema. So there is always a higher risk of aspiration and desaturation risk. It is like falling bricks. Defibrillation. Use standard energy doses. Remove fetal monitors or metal contact point before defibrillating. Drug dosing. It is same as that of the other ACLS patients. No changes in the medication dose. Reversible causes. Always considered static etiologies like massive hemorrhage, eclampsia, amniotic fluid hemorrhage. Resuscitation. Delivery timing. If no ROSC by 4 minutes, begin preparation for resuscitative delivery. Goal is complete delivery by 5 minutes to relieve aortovagal compression and improve maternal outcomes. Post-delivery priorities should be continue full resuscitation post-delivery, do not stop the resuscitation, manage hemorrhage aggressively, treat the reversible causes and coordinate with the neonatal team. The source of this slide is the AHA, the current 2025 guidelines. So this was in a whole about how the AHA has come about. These were just the highlights of the major changes which are being adopted in the 2025 guidelines recommended by American Heart Association. Thank you for your attention. We'll come up with the detailed presentations in our coming series.